So then I will continue on one of my subjects. Was asked to present on biopsies and liquid biopsies and are they confirmative, because there is a lot of change and a lot of development, and we know a lot on the genetics of uveal melanoma. We know that they have, if they either have a specific gene expression profile or either some typical mutations, then we know that that patients will develop metastatic disease and some will not. And all this information we can use to give the patient a prognosis, but we can also use it maybe for monitoring of disease activity and of metastatic disease. So if we go to biopsy techniques, there has been a lot of literature on the biopsy techniques for sampling in the posterior segment. We can do it either transscleral or transvitreal, and each of them has their advantages and disadvantages. And it depends on which technique you're used to, because you can make something which you're used to work for you, or either if you're not familiar with a certain technique, it will give you problems. So a lot of people do the fine needle aspiration biopsies, which is a needle, but we also have like the forceps for it, but we can also do it transvitreally with a vitreous cutter. And what I will do myself when I have a posterior pole tumor, which I can reach, I'm more comfortable doing transvitreal biopsy with a vitractor. And this is a patient which I biopsied, and afterwards you can see some complication, like a little bit of an hemorrhage, but it dissolves, and eventually you get like a plug inside of the place where you have done the biopsy. You can either do it transscleral, and I will do that for the anterior located tumors, and just go and use the SM4 step, because that works actually for me. But then what you do with the tissue you get from it, and it's a matter of size, because the more you get out of it, the easier for the pathologist is to make a diagnosis out of it and to use it either for gene expression profiling or to do any molecular testing, because the histopathology, that works in the majority of the cases, but for the molecular profiling or for the gene expression profiling, you need sometimes a little bit more tumor material. In our hands, we can do the molecular analysis, and we use actually the ion torrent platform, which we have added some extra genes, which are uveal melanoma specific, and we added also some SNPs, so we can say anything about the chromosomes 1, 3, 6, and 8. We have all the known uveal melanoma mutations, and sorry, it isn't in here, but we also have like the MBD4 mutations, and we also can evaluate the copy number variation on it. So you get a lot of information on just one single biopsy, if it works. And there are different techniques, because we work with the ion torrent platform, but there are also people doing the MLPA, but you can also do every other technique you want. So the take-home message for biopsying is that you have to select your patients, and we do them for undefined lesions or either for prognostication because the patient requested. But as we do it prior to any treatment, you also have to have your treatment plan already available and have made your treatment plan, because you have to do something with the outcome of it. And you have to optimize your pathology workflow, because there are really tiny biopsies and your pathologist has to know about them, that they're coming in. In general, there's a clinical misdiagnosis rate is less than 1%. And even if you have a negative cytologic diagnosis, that's no proof that the malignancy doesn't exist. Because if you're sure that it's a malignancy, you discuss it with your patient and maybe do another biopsy. Then we move forward to the newer era, and that's with the liquid biopsies, because we might be able to use liquid biopsies because it's minimally invasive. We do not have to go inside the eye. We can try to do a diagnosis, a prognosis, but also monitor the disease. And there are a lot of studies done on liquid biopsies to look at circulating biomarkers. So we can look at CTC, ctDNA, microRNAs, metabolites. So a lot is possible, but I will focus for this presentation only on the ctDNA. And then we have to question, can we use ctDNA for diagnosis and prognosis in uveal melanoma patients or in the small choroidal lesions? We have done a study in which we saw in 40% of the patients, like there weren't a lot of patients, ctDNA was detectable at baseline. And we looked at consecutive days during stereotactic treatment, and we didn't really see an increase of ctDNA. And there are limited studies on the subject, but also another study, they have like 30% of detectable ctDNA at baseline. And what they saw is that they had a bit ctDNA for the enucleated patients, that might be also the larger tumors, but they saw an increase in ctDNA after the plaque placement at day 2 and 3 after plaque insertion. So again, approximately 30%. And then we have the German group published on ctDNA. They also did not see anything at baseline, but they did see an increase in ctDNA after plaque insertion, and they also had it like between day 1 and 11, and they also had like 30%. So at baseline, only 1/3 of the patients will have detectable ctDNA. So it says something, but is it usable in the clinic? Not really. Then we have this publication on ctDNA in the anterior chamber fluid, where we know that they looked at ctDNA in aqueous humor, and they did it after radiation during treatment, and only in the ciliary body tumors they could find a copy number variation profile. I will skip this one because I'm going over time also. Then we have the next question. Can we use ctDNA or cfDNA for the monitoring of metastatic disease? That's a little bit easier, maybe, because we have a bigger tumor load. And in our study, we saw in over 70%, almost 80%, we could detect ctDNA during metastatic disease. And then the patient already has metastatic disease. And this is another study which we collaborated with a group from Australia, where we saw that the ctDNA negative patients had better survival compared to the ctDNA positive patients. And if we look at the time of metastatic disease, the patient with metastasis, if they were ctDNA negative, they even had a better survival. There aren't that many patients. And this is just an example of the patients. And we then think, if you have only localized disease, then you have like a low tumor load. And you do not really observe the ctDNA. And during metastasis, because the liver is generally full of metastasis, you have an increase in the tumor load. And that's why you have a higher, you can detect it. And if we correlate it to a log-transformed ctDNA, we saw that that it's like the metabolic burden of the tumor that indicates that we can identify the ctDNA. And then we might be able to use it for treatment response. And we have a few patients here, and the PD stands for progressive disease. When we look at the patient B, then we see it. If the patient has progressive disease, we see like an increase until that time of the ctDNA. And if the patient might react to the treatment, it will decrease. So it might be helpful to use it for progressive disease. And that's also what they did in the tebentafusp trial, that if the ctDNA was cleared, the survival was better compared to patients that still persisted, that still had the cfDNA. So in conclusion, there are some proof of concept studies that there is a potential of ctDNA monitoring in the clinical management of uveal melanoma patients, and that an increase in the ctDNA in metastatic uveal melanoma patients might be suitable in our hands for CMV profiling. So is there a clinical use of liquid biopsies in ocular oncology? For now, we only do it in a research setting and we do not use it in the clinic. And for metastatic disease is studied for the monitoring of metastatic disease. And we know that they used it in the tebentafusp trial, but they might also use it in the ipilimumab Novo trial. Thank you very much.
There has been some change of sequence to my presentation, there's some observations